This is the case of an eye which has had previous retinal detachment surgery and phacoemulsification. So what makes this surgery difficult is that due to logistical reasons, we have to do a DMEK in a vitrectomized eye using an 8mm graft from a young donor. So of course you would never want to do this if it were up to you to choose every aspect of the case, but sometimes because of the way the National Transplant Program works where we are from, you don't get much choice in these grafts. So we're starting off the case with stripping under air, and one of the things you need to be mindful of when doing this in a vitrectomized eye is not to hyperinflate the AC, because if you do so, air is very likely to pop through the pupil and move backwards and then be lodged behind the iris, where it's much harder to take it out from than it is for it to go in initially. So we're doing an 8.5 millimeters diameter strip, and then we're doing the inferior PI. If you can see through the pupil, all air has already gone through. So now what we're doing, we're opening up the pupil with the irrigating handpiece and then aspirating the air that comes out. You can observe if air has gone back, if you get a weird reflex in the pupil. So this is the graft that we're injecting, and it's very tightly scrolled, as is often the case in these young donors, or rather it's always the case, and more air comes through the pupil. So as has been mentioned previously in many videos from YouTube, techniques to unfold the graft in vitrectomized eyes differ wildly from techniques used in non-vitrectomized eyes. So what I usually do is use air inside the graft to have it stay open and keep the rolls of the graft apart. So usually when you do this, you want to have the one bubble that interacts with both scrolls to the right or to the left of the graft, but sometimes it doesn't happen like that. More bubbles come out than you want to, but that's no big deal because you can then go in and aspirate them and isolate just one bubble to hold the graft in place. And mind you, the graft is sitting on top of the iris right now with the bubble on top. Then through direct manipulation, we're using the help yourself maneuver to simply push the fold and have the graft sit more widely open. Now we're minimizing the graft, the air bubble just a bit, and now we have the graft fixated inside the inferior and nasal angles and centrally with the bubble. And this is quite a nice orientation to have, because from this position you are able to perform additional maneuvers and not have the graft roll up on itself. So now we're going underneath the graft with an air cannula and we're ejecting bubbles, and now we're going to aspirate the bubble that was on top holding the graft in place. So now the bubbles are underneath the graft. This is called double bubble maneuver, and it's very useful in DMEKs for vitrectomized eyes. Now with sweeping motions, we're centering the graft inside the markings that we have previously made, and we're quite happy with the result, because now all that's left to do is inject air behind the graft, and then that's the surgery basically. One thing to note is that in these vitrectomized eyes, air is very likely to move backwards immediately as the patient stands up. So what we've resorted to doing is injecting fluid inside the back of the eye to have a better pressure so that the air is not encouraged to move back to compensate for the differential pressure. In this case, doing so didn't prove effective because the next day the graft was totally detached and we had to go over this whole surgery again. The only thing that we did differently the next time was that we had the patient lie flat for 2 hours after surgery, and the next day the graft was attached. So as you can see, injecting air simply, in this case, moves back, and we're still exploring various options to prevent this from happening in future cases. Thank you for watching.